Welcome to Better Health for a Better World, a dedicated podcast series that shines a spotlight on global health projects and programmes supported by the Government of Ireland across partner countries in the Global South. I'm your host, Nadine Ferris-France, and together we'll embark on a journey to explore the remarkable initiatives transforming lives and communities around the globe. This podcast aligns with Ireland's international policy document, A Better World, which serves as a framework for our discussions. Each episode will feature interviews with one or two speakers who are at the forefront of implementation. Get ready to be inspired by the incredible changemakers working tirelessly to build a healthier and more equitable world. Welcome back to Better Health for a Better World. In this episode, our guests will discuss some of the successes and challenges relating to health systems strengthening in Tanzania. They will also highlight the value of development partnerships, of community engagement, and the pervasive issue of gender-based violence. Today, we welcome three guests to the series. Matthew Cogan, who is the Deputy Head of Development at the Irish Embassy in Dar es Salaam, joined by Dr. Trish Scanlan, who is the CEO of Tumaini Maisha, Hope for Life, or TLM as it's also known, and Dr. Ntuli Kapologway, who is the Director of Health, Social Welfare and Nutrition Services at the President's Office. We are absolutely delighted to welcome all three of you to the episode today. So perhaps I might start with you, Matthew, and just to ask if you could set the stage a little bit about Irish Aid's work in Tanzania. I mean, we know that Ireland and Tanzania have a shared history of colonialism, of political exchanges, and of course of development cooperation. So could you give us just a little bit more background and history on how Ireland has worked in partnership with Tanzania?
Thanks so much, Nadine, for having me on. It's really a pleasure and it's quite exciting. I think in terms of setting the stage on this, it's probably worth looking back a little bit in the history of both countries and the cooperation between them. I mean, we're both quite young countries. Ireland, we just celebrated our 100 years recently, and Tanzania also recently just celebrated 60 years of independence. But I think throughout that relationship, it's really been characterised by a sense of solidarity and a sort of a common experience, notwithstanding the significant differences between the countries as well, of course. I think Tanzania has really been through a journey in its approach to health. It's really worth noting that at independence, Tanzania had just 12 African doctors, and now there's 3,000. So this is a country that's really moving and has made huge progress in a relatively short space of time. It's also been through quite a journey, in that 60 years after independence, in a new emerging country, and went through a socialist project, and then went through quite a difficult time in the 80s with structural adjustment. In the 90s and early noughties, it was hit extremely heavily by HIV, and then more recently, it was also hit by the COVID epidemic as we were ourselves. And as Tanzania has evolved, Ireland's relationship with it has evolved, and I think the type of work that we're doing has changed over time to be appropriate to the needs of the country, from working very much at a community level, providing services, to providing finance for the national health system, engaging in policy dialogue and technical cooperation, which is the space that we're in right now. But I think through all that period, there's a common thread of solidarity and humanity that runs through it. For Ireland, we don't have any selfish motives for supporting health in Tanzania. We're not selling our pharmaceutical products here in a huge scale, or we're not seeking geopolitical influence from doing it. We do it because we believe it's the right thing, and a safer, more stable world and a more healthy world is in all our interests. Right now, health is actually the largest part of the Embassy's development programme in euro terms. In the last 6 years, we've given over 80 million euros to support health in Tanzania. That focus is very much going with a community-based approach. We focus on primary healthcare, sexual and reproductive health and nutrition. And right now, the Embassy of Ireland has taken a leadership role in coordinating the work of all the development partners, donors and UN agencies on health as the chair of the Development Partners Group. But yeah, I think it's really a long, rich and fascinating history that we have with Tanzania.
Yeah, thank you, Matthew. And I think one of the, as you're describing, public health care and community-based care and sexual reproductive health and nutrition, it's really talking to health systems. And I wonder, Dr. Ntuli, if I might ask yourself, just health system strengthening. You could maybe just speak a little bit to that in terms of what does it actually mean, strengthening the health systems, and why is that crucial for improving overall health outcomes?
Thank you very much. And I appreciate for having me in this podcast. Well, when we speak about the healthcare systems, means the organization of the people, the organization of resources, institutions that are geared towards improving the service delivery while meeting the expectations of the people. So Tanzania, like any other country in the resource-limited country, has forged a partnership with different stakeholders, including Ireland. And Ireland is one of our key and strategic partners with whom we have done so many things, which we are focusing towards strengthening the healthcare systems. And I must say that through the partnership and collaboration which we have endured with the Republic of Ireland, which led to the strengthening of the system at different levels, not only at the tertiary, not only at the secondary, but also at the primary healthcare level. And our healthcare system in Tanzania assumes the pyramid shape. Well, at the base of the pyramid, we have the communities, and within the community, we have different community structures that are responsible with system strengthening, including the governance structures like the Health Facility Governing Committee, the health committees at the community levels, but followed by now facilities at the primary, secondary, up to the tertiary level. So when we speak about the healthcare system strengthening, it means those organizations which are happening at the communities, at the facilities, but also which involve different stakeholders that are supposed to, or those are focusing on strengthening the healthcare system. So I must say that we have had some journey from independence to date, but as time goes by, we are trying to see and we are witnessing a great change and transformation in our healthcare system, not only due to our government, but also with our development partners, the non-state actors, and the community as a whole.
Yeah, thank you. Thank you, Dr. Ntuli. As you speak in terms of the health systems, I know in one of our recent podcasts, speaking to colleagues in Ethiopia, they were talking about the systems of health. We say health system strengthening and then the systems of health. Matthew, I might just come back to you just to ask you, in terms of, you said that Ireland is at the moment the lead in the health sector among the development partners. And perhaps, from your perspective, what are some of the challenges, as you hear Dr. Ntuli speak, what are some of the challenges that you're seeing in terms of health system strengthening in Tanzania today? And specifically, how can Ireland play a role to support some of these challenges?
Thanks, Nadine. Yeah, I think notwithstanding the enormous progress that Tanzania has made, there are still huge challenges remain outstanding in strengthening the health systems. I think I'd like to highlight 4 of them. The first one is human resources for health. Tanzania is experiencing a 60% gap in human resources for health, and that's particularly acute in remote rural areas. So there's not enough healthcare workers at all levels, from specialists, doctors, nurses, clinicians, the whole range. And whilst the availability of health infrastructure has increased very, very, very rapidly over recent years, the country is facing a major challenge in staffing them, and in some instances you have health centres that have been built but lie empty and unused simply because they're not staffed. Second challenge is financing. Tanzania recently became a lower middle income country, so there is a growing capacity in the country to finance its own health system. But at the same time, there's still a fairly significant level of dependence on external financing. It's worth bearing in mind, just to have a sort of sense of scale. The annual budget of the Ministry of Health here in Tanzania is roughly equal to that of Limerick University Hospital. So think of that scale of trying to provide services for 60 million people with that type of budget. There's also an allocation issue, particularly the end of diseases, and you're seeing much more non-communicable diseases such as diabetes, hypertension, and cancers, etc. So that's a fairly significant challenge for the health system in Tanzania to pivot away from very communicable disease and maternal health focus to one that's addressing a wider range of needs.
Yeah, thank you, Matthew. Just really interesting when you're looking at the kind of overarching issues, human resources for health, financing, population growth, and then the nature of the needs, the changing nature of the needs. And I wonder, Trish, I might just come to you. Matthew mentioned there just, non-communicable diseases, and given your work on pediatric oncology, I know I was reading and some of the amazing work that you and your colleagues are doing, that with childhood cancer survival rates, it's been transformed drastically over the past few years, from less than 10% to now over 50%, and that the number of kids being treated has also increased. Perhaps you could say a little bit around what TLM specifically as an NGO has done, and yourself as a clinician in the hospital, really dealing day by day with these, the human resources for health issues and the needs. If you could say a little bit to that, Trish.
Yeah, sure, Nadine. And again, thank you for this opportunity. I'd also like to maybe sort of, I'm one person and TLM is one organization, but we have been working hand in hand with the government and with government health institutions from the very, very beginning. And that, I think, has been key to our success. From the very beginning, we were embedded in, first of all, the Ocean Road Cancer Institute, and then moved to Muhimbili National Hospital. In fact, our main offices are in Muhimbili National Hospital. And so it's hard to know on the oncology ward where TLM begins and where Muhimbili ends. And that's, I think, part of the collaboration that has made it so successful. So just in terms of the types of things, in terms of health systems that we have been part of and helped to strengthen, in terms of, if we go through Matt's list, the first was human resources, right? It was education, human resources. So we identified that as a massive issue, and have worked with primarily Muhimbili University of Health and Allied Sciences. And we created a master's program, which is now a fellowship for pediatric hematology oncology subspecialists. And it's one of the things that we're really very passionate about, which is the training to occur either in country or at least regionally. And this it is obviously key to prevent the brain drain that we will know about. It's not to say that we don't want to have collaboration with international partners. And I think that's key. I don't think any institution, particularly any health institution, is better working in a vacuum. Everybody is better working in partnerships. And I have been very lucky being Irish, because both the Irish government through Irish Aid and also the paediatric hospital system in Ireland has been involved from the very beginning, helping to strengthen and to support any of the programs that we've been doing. So one was health services, one was finances. And as Matt has said, and I always argue, because say we're looking after children with cancer, and somebody might say, well, why doesn't the government do it? And I always push back and say, well, does the American government do it? Like, there are a few countries in the world that manage to support all services for patients with cancer or patients in general. And obviously, because they have, very impressive tax systems. So I don't necessarily believe that the government should be doing everything. And that's where we should have very powerful and kind of partnerships that are targeted in one area, like we are. So we're the cancer charity that tries to fundraise, and we're the charity of the gaps. So the government does an enormous amount of work, and all the hospitals that we work with across that country, they're all either government or faith-based hospitals, and they're all providing care to children in a standardized fashion. And that's one of the things that we've tried to do, is at a national level, bring everybody together so that we have national protocols where there's a voice at the table for everybody around the country. And it's being led internally by the Tanzanian doctors and nurses and parents as well of the children, which I think is very important in terms of having a voice at this. And then bringing in, businesses and very successful people so that they can help with funding, because funding is an issue. But I very strongly believe that, in all of this, we should be keeping the patient, in my case, the children, at the center of this, so that we give them the care they need, not the care they can afford. And that's why financing outside, with obviously in partnership with the government, but outside of the government, is essential to bring in, these organizations that are very wealthy to help us. The number of patients, yes, we have a massive increase in the number of patients. When I started in 2006, there was 120 new patients who were receiving care for children's cancer at one site around the country. Now, we identified that as things grew, we identified that as something that was going to be a big problem if we kept it small and within one institution. And that's why, as a charity, and again, working alongside the government, we expanded the option of care and all the kind of support that we give. So we pay for the chemotherapy for every child in the country. One of the largest hospitals here takes samples from children all over the country. They can be sent to the main hospital here in Salaam to try and standardize diagnostics. So children now can receive care in up to 15 hospitals around the country. Because our numbers have gone from 120 to last year, just under 1,000 children. And as a result, we would paralyze one hospital if every child came to that hospital. So that has been something that we've been building. And again, taking advice from all our regional partners. Where is the next centre that's ready? Where does the government want us to go to next in terms of funding and supporting hospitals? And then the changing need. And I 100% agree. Some of it is that the cancers maybe are changing a little bit, and they are. We're seeing more leukemias and less of a lymphoma type picture, and some of that is related to poverty, and the reduction in poverty that we're seeing in Tanzania. But there's also, as the health services in other countries are moving forward with new technologies, Tanzania is not being left behind. And it's really important that Tanzanian patients and Tanzanian health services is not left behind, because every child in Tanzania is as precious as every child in Ireland or any other country. Obviously, I'm talking about children because that's who I look after. And so what's very important for me is when I look at an issue like access to a high-tech investigation that a child needs, or a new treatment, you have to think of it in two ways. You have to think of it, the child that's in front of you right now, and how do you solve it for that child? And then also, how do you solve it for the children who are coming in the future? And there might be entirely different solutions to those two groups of children. And you may need outside support if something is not in country. Always making a path towards, bringing something internally and making sure that you're strengthening the service in the long term without forgetting the child who needs it right now today.
Thank you, Trish. And thank you for never letting us forget the child at the centre and the patient at the centre of all of these discussions that we're having around health. Dr. Ntuli, I wonder if I come back to you, again, just using that framework. I think it's an interesting framework, perhaps around, population growth and human resources for health. I heard it was Matthew who said that we have 3,000 doctors. I think that was correct. It was Matthew who said that 3,000 doctors now in the country. And then, just looking ahead into the future, what kind of challenge is that going to pose with population growth, and what kind of actions are you already taking? I'm sure, just thinking about how to support the health system as the country grows.
Thank you very much, Nadine. And before I proceed, I must commend Trish. I have heard very good things about Trish, the contribution she have had into the Tanzanian healthcare system. So to me, I feel very much indebted to her, and I must congratulate her for what she is doing. And I pray for her that she should be able to reach out to every child in need in Tanzania. And I believe we will work with her. She's been working with my wife for many years while she was working at the Muimbiri. So I'm happy to be with her in this podcast today. With regard to, so keep it up with Trish, and we are very proud of you. With regard to human resource for health, for the past 5.5 years, the government of Tanzania have invested heavily into the healthcare system by construction of new facilities in the country, are trying to reach a goal of having a facility in every 5 kilometers. And for the system to be working, we need different stakeholders from different levels. And Trish is one of the very important stakeholders. We as a government alone, we cannot be able to reach out to all the people out there. We need different stakeholders, both bilateral, and non-state actors as well. And Trish is one of the people whom the government of Tanzania has been working with in trying to make sure that the services provided to the people in need are always there. And with regard to the framework, well, Maisha said it very well that with rapid population growth, we'll need to come up with different strategies and approaches that will help us to be able to address that challenge. And one of the things which the government of Tanzania is trying to do now is to embrace technology, the use of telemedicine. For those who are working in hard-to-reach areas, the medical doctors and nurses, they should be able to get the expertise from those who are working in the urban areas through the technology. And the telemedicine is one of the technologies which we are currently rolling it out to the entire country. Secondly, there is an issue to do with task shifting. For instance, we were able to buy a number of diagnostic tools and equipment, but we learned that those who are supposed to be deployed to be able to run those facilities, they were not there. So we had to train the nurses, the clinical officers, and the medical doctor to go for radiographic training. That is a short course. So that's to help to be able to offer these services. So there are a number of initiatives which the government is trying to do in addressing the shortage of human resource for health. And hopefully, we believe that with that one, we'll be able to address the shortage of human resource for health. But of recently, I, with my colleagues from different sectors, we were writing a book, and soon it will be out, trying to document what has happened in the primary healthcare system before independence and after independence. And the book goes under the title of Primary Healthcare in Tanzania Through the Health System Lens, a history of struggle for a universal coverage. So under that book, we kindly tried to challenge the WHO framework, which points out about the 6 building blocks. So we think that there are some other building blocks which must come into play, one of which is the issue of the political determinants of health. We need the politicians. We need to get their buy-in for them to be able to communicate and own the healthcare systems. We need the commercial sector or the private sector. You know, much as we are preaching about the healthcare system, but without engaging the private sector, then we want to be able to actually reach where we want to go. We need their support because the government alone cannot provide everything. As of Tanzania, 60% of all the health services is provided by government, 40% by the private sector. So you cannot underestimate the role of private sector. We need the private sector to be at the core, to work hand in hand with the government to provide services. And there are these social determinants of wealth. And this was partly touched by Trish, the health-seeking behavior. At what time someone goes to the facility, there are a number of factors. Is it the issue to do with awareness? Is the issue to do with poverty? There are a number of factors. So we need to unpack these factors and address each factor accordingly. So we think that partnership and collaboration, engaging the private sector, embracing the innovation technology, these are some of the things which will help us to address the issue of human resource for health with our rapid growing population that in the next 15 years will be 100 million people. So we need to have a robust and a very strong health system from the primary level, secondary up to the tertiary level. But being flexible and also being adaptive, these are what are needed right now to be able to cope up with the current situation and the situation to come. Thank you.
Thank you, Dr. Ntuli. And even the number 100 million, coming from a country of 5 million, I think we're kind of at our biggest now in some years. It's just hard to even imagine that number. Matthew, I might just circle back to you just for any comment you might have on what you've heard there, just shared by Dr. Ntuli and by Trish, and also ask if you might just say something around community healthcare workers, because I know that Ireland specifically has been involved with development partners in supporting training for community health workers. So over to you.
Thanks, Nadine. Yeah, I think you really just read my mind there. That's exactly what I was hoping to talk about. I'd like to start by saying that I fully agree with everything Dr. Ntuli said, including his praise for Dr. Trish. Ntuli mentioned the WHO building blocks for health systems. I'd like to also add to that, if I may, community engagement is so important for a functioning health system. And Tanzania has actually some quite good practices in that regard that actually other countries, including Ireland, could learn from. They have a system of community health workers. And these are people that are volunteers or people that are receiving quite small stipends that are from the communities that they serve, that go house to house, speaking to people in their own languages, identifying people that maybe might be pregnant or malnourished or have a specific health need, providing them with basic health messages and referring them then to healthcare centres. I've seen it myself here. It's really quite impressive. You see people cycling around from house to house, sitting under trees and talking and listening to people and providing them accurate health information. And in the context of the increased demand for health services with a growing population, and the challenges of human resources for health, I think that role of community health workers is very important. Ireland, we've been supporting community health workers through a number of our partners, and as have many other development partners. But we need to do better in how we do it. But funding and that support has been quite fragmented according to the interests of the donor. So, if someone is interested in HIV or TB, then that's what they pay the community health workers to do. But that's not appropriate for people's lives. We don't none of us live our lives one disease at a time. We have complex and interlinked health needs, and we need to enable the systems to respond to that. Right now, we're really happy to support the government, which is really driving reform on that for a more integrated approach to the community health workers. that is more sustainable. There is some really great work being done on this in Tanzania, and definitely it's the community health workers are part of the solution to the challenges of strengthening the health system.
Thank you, Matthew. Well said. And Trish, I might just come over to you. Just as we're speaking about community and we're speaking about solutions for how to deal with the challenges that are even yet to come, not alone the challenges that we're dealing with now. And I know that during COVID, you had a very interesting approach where, we were all challenged in so many ways where people couldn't get to the hospital. The children weren't able to get into the hospital for care. And you worked with communities across the country and came up with a different model for how to get children into care. That is something that has continued past COVID. Perhaps you could speak a little bit to that and, anything else around your perspective on community.
Yeah, thanks very much. And that's part of the reason why we started looking at the National Children's Cancer Network, which we have built. It's not quite at the community level, although we do try and do the health messaging at the community level. We work with hospitals or health centres of any size because they can get involved even if they can't treat, but they see patients, that they at least know how to access the services that we can provide, for example, the transport for the patient. So they don't actually have to have made a diagnosis. They literally can just ring us up and say, we have a child, he has a mass, we think it could be cancer. And if we agree, then we will send them the money so that the child can get to the next level site. We're hoping to expand that so that no child is more, initially what we're saying is no more than a 4-hour journey from a site that's part of the network. And in that case, those sites, as I say, they're not all treatment sites, but they're sites that just know what to do when they see a child with cancer. Because one of the big things for childhood cancer is obviously urgency. And I'm here 16, 17 years, and we're still seeing children come in with end-stage disease, which is just really heartbreaking at this point, that we're still not getting the message out there loudly enough that the cancer treatment works. The cancer treatment is available to all. It doesn't matter if you're Nkulima, if you're like someone who's just works your own small plot of land and has no money, or if you're a business executive. That's one of the most important things, and has been possible only because of the way the health system has been built in Tanzania to be equitable from the very start. And the other thing I always, because I know people kind of maybe say with a health budget like what has been described here, why are we concentrating on cancer when there are so many more competing diseases? And it is true that cancer, particularly childhood cancer, adult cancer, is really a big, big, big problem all across the world, including Tanzania. And maybe childhood cancer is not such a huge challenge compared to malaria and all these other things. But the pushback that I always say is, well, number one, we know that these kids are curable. Like in Ireland, 85% of children with cancer are cured, and Tanzanian children get the same diseases. There's literally no reason except for poverty and delayed access that the kids are not getting the same amount of cures. Even though we have made progress, we're still far from where we need to be. So we need to cure these kids. These kids shouldn't be dying. So that's one. But the second thing is, as Matthew was talking about, a lot of money would go into these silos of TB or HIV, and those services can actually run parallel to a functioning health system, or maybe a non-functioning health system, not in the case of Tanzania, obviously, but they can come in and have these programs that just work for TB or just work for HIV and do nothing really to strengthen the overall health service. Whereas childhood cancer and any cancer really cannot work and will not be successful unless every aspect of healthcare from the community level, where people are actually help seeking at the right time, to those smaller hospitals where people are recognizing the cancers and transferring the children or having the basic investigations they need, to obviously a big university hospital like Muhimbili National Hospital here in Dar es Salaam, where they have to have procurement, supply lines, excellent nursing, radiology. They have to be able to take children to theatre at 2 a.m. and have an anaesthetist on standby. They have to have pathology to make accurate diagnosis. And if you do it for a child with cancer, you can do it for any child or any adult. And that's what we have been doing over the last 15 years. Is it's not just the ward that we've built or the hostel or, providing chemo, but we bring international and local specialists together to strengthen pathology, to strengthen leukemia diagnostics or laboratory services. And in that way, it's the whole, isn't it, the rising tide that raises all boats. And that's genuinely what the model of childhood cancer can do. It can, if it's rolled out successfully and in partnership with every department that needs to be involved, then other services they just have to benefit from the same efforts because they're using the same services. So that's, I think, what's so exciting about the oncology model.
Yeah, thank you, Trish. And as always, you're very, very passionate about this, and it makes all of us passionate and look at, what more can we be doing, as we come to the end of our very short discussion, because there are so many important topics to discuss and so many perspectives to hear. Matthew, I might come back to yourself. I know that gender is one of the very strong pillars of Irish, the Irish AIDS development policy, A Better World. So perhaps you could just say a little bit about that, and also if you were to leave us with a message or a call to action, what would it be that what would you like to convey to listeners who are passionate about global health and also about creating a better world?
Ireland's relationship with Tanzania and our investments in development here, they're really about investing in people. We're not in the business of building football stadiums or roads or factories. We're about people. And gender equality is at the centre of really everything we do across all sectors, be that in health, where we have a strong focus on sexual and reproductive health, or agriculture, we're supporting small women farmers, humanitarian, looking at the specific needs of female refugees and gender-based violence, to governance issues, the role of women in decision-making from community level up to national level. Right now in Tanzania, I think we're actually quite lucky. We have quite a positive enabling environment in terms of working and on gender equality. We have the first female president in the history of Tanzania, Samia Suluhu Hassan, and she's taken quite a bold personal stance on sexual and reproductive health, and we're very happy to get behind that. It hasn't always been such a conducive environment, and sometimes it's been a little bit uncomfortable to talk about issues related to sexual and reproductive health and rights. But I think we've been quite consistent on it in our respectful and partnership-oriented way. I think you can see from the discussion today the very warm relationship between Ntuli, Trish and I think that's quite indicative of the generally very positive relations between the government, development partners and civil society. We do have quite a positive environment here. On your second question, I think probably Trish and Ntuli are better placed than I am to answer that, but here's a few thoughts anyway. I think the first thing would be to stay curious, take time to listen to people, to sit under a tree or wherever that might be, and just listen to patients or people experiencing health, and the service providers, the people on the front line providing those services. They are the true experts. Secondly, I would advise people to take a holistic approach. Ill health is not just a question of diseases or pathogens. It's complex. These are complex social phenomena, and I think we need to address them in all their multiple aspects. So really taking very much a public health approach. And the last thing I'd like to say is to focus on climate change. We can see in Ireland and across the world that climate is really changing very rapidly, and we can see that right now in Tanzania. The patterns of rainfall it's changed dramatically. We're preparing for El Nino right now here, and as that continues and most likely exacerbates, that's going to be a very significant challenge to the health system in terms of extreme weather events, which will weaken its capacity to continue to provide services. But it's also going to contribute to changing patterns of diseases. You have vectors such as mosquitoes in places where they have never been before, contributing to to diseases that maybe weren't familiar in some areas, and even novel pathogens that are likely to appear. We don't know what the next COVID-19 is, but we know that it will come, and climate change is driving that. So really thinking about climate change and health security. Thanks.
Thank you, Matthew. Thank you. Very, very well said. Trish, coming over to you. As I said, you inspire us. You inspire a lot of us, both here in Ireland and also in Tanzania. But what message or call to action would you like to leave us with? What do you want to let the listeners know? What can they take away from this episode?
Well, I probably would like to just highlight that, we get so much bad news, and that Tanzania is not one of those stories. Tanzania is a really good news story. And, my kind of call to anybody who's involved in healthcare or, making decisions in health is, when you're making those decisions, whether it's on a ward or in a government, is to keep, or a donor, is when you're making those decisions, put the child or put the patient right at the center of those decisions. When I came to Tanzania first, we overnight just decided that chemotherapy was free on the ward, with literally not a cent to pay for the chemo. And the children, we got the chemo in without any way of paying for it. And the children got better. And as a result, people started supporting us. So waiting for everything to be perfect, waiting for all the money to be there to make the right decisions. You make the right decisions and people will follow you. And that's what's happening in Tanzania. And we just need more brave people to step up and be the voice of the patients that need them.
Thank you, Trish, for being one of those brave people, and all of you on this episode. We're really grateful. Dr. Ntuli, last word from you, a message or a call to action that you'd like to leave with the listeners.
For me, it's just to continue working together. Disease has no boundaries, so we need partnership from different inside and outside the country. And we have seen that through partnership, we have made a number of strides, and we should embrace that. And for us, we are quite very grateful to the government of Ireland. Apart from the support we are getting through the basket fund and some other sectors, but now we have started having some partnership with University of Dublin, where we want to actually empower the primary health care in the gender. So we have the gendered leadership program for the primary health care, trying to identify women, ladies who can lead, but at the same time taking care different age strata to be part of that. So with this combination of different interventions will surely take us to where we want to go, which is universal coverage, but at the same time, reaching out to the Sustainable Development Goal number 3. And this is possible. And what I would encourage is to continue working together, having champions, having models like Trish, like my friend Matthew, who are committed 24/7. This will help us to be able really to meet people's expectations. Otherwise, I'm super happy to be part of this podcast today.
Thank you, Dr. Ntuli. And I'm taking away from, if I was summarizing the 3 things that you said, I'm taking away courage, bravery, I'm taking away curiosity, and I'm taking away leadership. Thank you, each and every one of you, for joining us today.
And that brings us to the end of another enlightening episode of Better Health for a Better World. We hope you enjoyed our exploration of the remarkable global health projects and programs supported by the Government of Ireland. Remember, by investing in the health and well-being of communities around the globe, we not only create a better world for those in need, but also foster a more interconnected and compassionate planet. We encourage you to stay engaged and to take action, as each of us has the power to make a difference. Thank you for joining us on this journey towards better health for a better world.